I'm very pleased that we have a wonderful panel to talk about an issue that is, I think, a very important problem in public health. If we could go to slide number 7. Many of us were unaware of the seriousness of the problem of addiction and mental health in our society prior to 2015, when a very wonderful study was published by researchers Case and Dayton. And see, I'm looking for number 7, that showed really for the first time in the history of our country and probably the history of humanity, that we were seeing an actual rise in the rate of mortality, surprisingly, among people in midlife between the ages of 45 and 64, white non-Hispanics in the US. And if you go to slide number 8, when the researchers began to take this apart, dissect this rise in mortality, there were 3 conditions that were responsible for it, one being poisonings, the other one being cirrhosis of the liver, and a third one being suicide. So if you go to slide number 10, an important finding then was that actually these 3 conditions were going up in mortality rates, not just numbers of people, but rates of mortality in all age groups in the United States. It stuck out in the younger white age group because there weren't many other competing causes of death, but actually we are now seeing overall increases in mortality across especially white non-Hispanic people in this country, that not only has this trend continued, but it's gotten worse. If you go to slide 20, and we can see here, and you need to play this. It's a video. I don't know how you do that on your system. Just click it once. Click on it. What this reflects is what has been occurring in terms of the rates of overdose deaths nationwide, primarily driven by opioids in this country between 2009 and 2014. And I think that this gives you a dramatic picture not only of the extent to which this is occurring, but how this is occurring across a broad swath of the country. Yes, on the coast, but also across Appalachia, across the Midwest. Not a problem that's necessarily confined to what people might think are inner city areas, typical urban areas, but all kinds of areas where one in the past maybe had not been thinking, although in retrospect there always had been problems of addiction in those communities, but this epidemic of death certainly being a leading indicator of something very important that's happened in this country. And as the last picture for you, slide number 12, as the Centers for Disease Control have begun to dissect these what has been very clear is that there's been a steady increase of death from heroin overdose, but also very sharp increases in death from other kinds of narcotics, the synthetic narcotics that have been in recent years causing very sharp increases in overdose death rates. So I'm a professor and a dean in public health. I'm at the Milken Institute School of Public Health. And in public health, we are very concerned about finding ways to prevent problems like this. We have a paradigm of primary prevention. You try to prevent people from, for example, becoming addicted in the first place. Secondary prevention, you try to find early signs of a problem where people are beginning to use, and what can you do to prevent that. Tertiary prevention, people perhaps have an addiction problem, but we don't want them certainly to die or to have disabilities from this. And so we've assembled a really wonderful panel here to help us to address those questions. And I just want to take a moment to give you a word or two about these folks. There's a more comprehensive bio available for you in the program materials. But we first have Thomas Insel. Tom is the team lead for Verily Life Sciences. He directed the NIMH for a number of years. He's a psychiatrist. He's a neurobiologist, one of the top scientists in this field. We also have with us Gary Mendell, who is the founder and CEO of a not-for-profit called Shatterproof, which he has led for 13 years, and as he says, is 3 years, sorry, and is building, as he says, the American Cancer Society for Addiction, which is a very ambitious undertaking. We also have with us Richard Pops. He's chairman and CEO of Alkermes. It's an innovative company that develops new treatments for central nervous system disorders, including addiction and related problems. We have with us Garen, who is founder and chairman of the One Mind campaign, another very innovative not-for-profit, very much supports open science and has raised $270 million in support of research in this field. Very, very important contribution. And Nora Volkow. Nora is also a psychiatrist and a neurobiologist, a fabulous researcher. She is director of the National Institute of Drug Abuse. She's just celebrating her 14th anniversary there. And so to kick off our discussion, I thought I would go back to the issue that I put before you at the beginning, and to hear from each of our panelists about your perspectives, okay, on this issue of not only addiction but also the connection to mental health, and why us, why now, and where should we focus, or where do you focus around this issue of prevention very broadly, and perhaps starting with Tom.
Well, thanks, Lynn. Maybe what I can do to start off is just to fill in some of what you've already seen in the way of the data slides. Let me share with you just a few numbers. We usually think more about morbidity than mortality, and on the morbidity side, neuropsychiatric disorders have become now the leading source of disability-adjusted life years, largely because, in contrast to everything else we'll talk about at health in this conference, and in contrast to most of what we think about in medicine, these are the disorders of early life. You can just quickly summarize that by saying 75% of people who will have a behavioral disorder, mental disorder, or substance abuse disorder will have onset before age 25, 75% before age 25. So we're talking about something that's very different than when you look at the demographics or prevalence of cancer, heart disease, diabetes. That's the morbidity side. Lynn's already been talking about mortality, and the numbers she gave are really worth underlining, that we're talking about 33,000 annual deaths from opiate overdose, 44,000 suicides per year. Provide some context for that. We're looking at about 40,000 breast cancer deaths a year in the United States, so more suicides than breast cancer deaths, 29,000 prostate cancer deaths, and maybe even a more relevant number is about 17,000 homicides. So 3 times as many suicides as homicides in the United States. Just process that for a moment, because that is not what you would think from reading the paper or watching the news or reading Twitter. It's really a quite staggering number. And perhaps what's most concerning about that number is that it is going in the wrong direction. While we have been able to reduce homicide by about 50%, 48%, we've been able to reduce traffic fatalities way down so that they're in the low 30,000s in the United States. These other numbers, you saw the data for opiates, but even the numbers for suicides generally continue to trend up over the last 20 to 30 years. So this is a place where whatever we have been doing, whether it's in the realm of prevention or treatment, it's not working. And we do need to now think about how to approach these problems as real public health problems. This really is a public health crisis just on the basis of the mortality numbers alone. And to rethink the approach so that we do something very, very different. I'll leave it to all of my colleagues up here to throw in their best ideas of how we might do that. We'll circle back, and I'm sure we'll have a pretty interesting discussion about this.
Hey, Tom, just to make a point to amplify the data, those numbers don't include the 20 more people who try for everyone who's successful, right? In suicide. So we're talking about 1 million people close to that
in
who
terms
are in
of
such
attempts.
state of despair that they feel like not living with this illness is better than living with it.
So Gary, your perspective.
Sure, I'll just add one more number to that, and then I'll talk about prevention, which is the numbers that Tom mentioned. He mentioned they're going in the wrong direction. Suicides have doubled in the last decade, doubled. And Tom mentioned 33,000 annual numbers for opiate overdose deaths. That was in 2015. It was 6,000 15 years earlier. It's almost 5 times. So, and it'll be, when the numbers are announced for 16, everyone expects they'll be in the mid to high 30s, up another 15% from the year before. So they're rising dramatically, which I think puts it in context also. As far as prevention goes, I'm going to narrowly focus on the opiate epidemic for a second. And others, Tom just spoke more about broader mental health, behavioral health. For the opiate epidemic, look, ending the opiate epidemic is very, very difficult. But cutting it in half is really not. It's really not. It's actually fairly simple. There's not an expert in this country that would disagree from the cause of the opioid epidemic. The number of annual prescriptions of opioids started increasing rapidly in 1995 when the FDA approved slow-release oxycodone called Oxycontin, which you've all heard of. Upon that release, there was a huge marketing campaign by the pharmaceutical companies, which convinced the healthcare industry that these pills, because there was a different type of pill, it was slow release over 12 hours versus quick release over 2 hours, was not addictive and not dangerous. Putting aside blame, doesn't really matter, but the healthcare industry accepted that and changed their prescribing habits, starting in 1995. And what you've seen since 1999 to last year is literally, factually, a 4 times increase in the amount of opioids being prescribed on an annual basis. It went from only prescribe them for a couple days for surgery or active cancer treatment or end of life to every ache and pain, because doctors thought they were now not dangerous. And you saw a 4 times increase in pills from 1999 to last year, from 60 million prescriptions a year to 240 million prescriptions a year, enough for every adult in the country. Put aside blame, it doesn't really matter. 4 times increase in pills, almost, as I mentioned, 6,000 to 33,000, it'll be 35,000 this year, to 36,000, in 16. 6 times increase in deaths. Really not rocket science. I'm not a scientist. 4 times increase in pills, 6 times increase in deaths. You could say it's correlated, or you could say it's causal. I'm not the researcher, but every expert in the country says it's causal. So if we can take the pills down to a balanced prescription rate, which I'm not saying it should be down to 60 million prescriptions, those who really need the pills should get them. All I'm suggesting is every doctor in the country take a pledge or be required to read the CDC guidelines that were issued 13 months ago. Every doctor in the country should have to read those guidelines, study them, and adopt them as a voluntary standard of care, because they're guidelines. They're not dictating what you should do. If every doctor in the country was mandated to read those guidelines, study them, and adopt them as a standard of care, which gives them flexibility of what to prescribe, or they lose their ability to keep prescribing opioids. They can still be a doctor, but they lose their ability to prescribing opioids. You would have the number of pills prescribed on an annual basis go down by about half in round numbers. And you would cut the funnel of new people becoming addicted by about half. We could talk for hours about how you get rid of the other half. That's a quick hit, simple, costs no money, and could be done instantly.
I'm in for that.
Thank you.
So I run a biotech company, and we've been interested in the neuroscience of addiction and developing medicines for this space. And it's fascinating because about a decade ago, we developed a medicine, and we thought getting it approved by the FDA would be the end of the story. People would beat a path to our door, and we would help a lot of lives. And only then did we get steeped in the complexity that represents treatment of opioid addiction and alcohol dependence in this country, because it's a non-medicalized subspecialty of medicine. It's not driven by evidence, it's driven by lore, and there's so much to be done. I contrast it to the treatment of oncology, where every June people get together at ASCO, they present new data, and the next week treatment guidelines around the country change based on evidence. Whereas in addiction, evidence is not central to the treatment decision. In fact, most people who are treated for opioid addiction do so without a doctor around, only with counseling. We spend billions of dollars as a country doing it. Others can talk more about that. The other piece I just wanted to mention at the outset, though, because supply, the why is there an opioid crisis, that the point that Gary just made about supply is self-evident. There's just way too much of these available. Doug Throckmorton from FDA describes it as the country is awash in a sea of opioids. And with the generic laws, ANDAs, or generic medications, can get approved without clinical trials, and more dosage forms become available at lower and lower price. We're actually interested in our company now on the other aspect of the why, which is the demand side. Why do so many people like to take opioids for so long? And originally the notion was this idea of chronic somatic pain, back pain or neck pain, but the circuitry in the brain that's activated in the context of somatic pain are the same circuits that are activated in the context of social rejection and other forms of psychic pain. And many people are taking these opioids they might get introduced to them because of a legitimate prescription need, a knee replacement or a hip or something, but they're feeling better on these opioids. So we're entirely fixated now on this idea of non-addictive medications that address those systems in the brain that deal with psychic pain, and encouraging more elaborate or detailed differential diagnosis so a physician understands why this patient continues to seek these opioids either through a legitimate or an illegitimate route.
If I could add one more fact to that. There was a study that came out just a month ago or 6 weeks ago, and it showed that patients who took an opioid for 5 days or less were approximately 6% likelihood to be on an opiate a year later or more. And once it reached 8 days, it immediately jumped to double, about 13%. And so it's a lot of what Richard just said, but it's coupled with the addictive capability of these pills. And tying it back into what I said, the CDC guideline says, again, it's voluntary guidelines, but it says doctors should understand that most circumstances, the patient will not need an opiate medication for surgery or anything more than 3 days. And if every doctor in that country followed that recommendation, they still have the ability for the patient to come back in 3 days and get another day or two if they need it. But to give 30 days, which is regularly done in this country, 13 months after the CDC guideline came out and recommended against it, is just, other countries have to be looking at us and say, what are we doing?
So, Garen.
Yes, thanks. Could I have slide number 1, please? So our work over the last 20 plus years has really been in the area of fundamental research in cooperation with NIH. Dr. Collins is here in the back room and during the time that Tom was at NIH, we've had the opportunity to fund early research for scientists that were sort of in the grade of being able for an R01 grant and other things to really try to propel new breakthroughs that go forward. But over the last year or so, in addition to doing this effort, we've actually taken the position that one of the best ways to address all mental health problems, and in particular the issue of substance abuse, is to really go to the workplace. Because this is the place where people spend most of their waking hours. It's the place in where stigma and discrimination has a great deal to do with people's willingness to access care and the coverages that are available to them. And without that freedom and that opportunity, people are not taking advantage of them. And many times these use disorders, I think that's a term people feel more comfortable in using instead of substance abuse, is a result of either their own self-medication profiles as they go about doing that. So much like 25 years ago, President Bush 41 created a CEO roundtable on cancer with the idea of establishing a gold standard of behavior for corporations to employ throughout the workplace. We are trying to do the same thing now for brain health. And the facts that are up there are pretty much self-evident. This is a $1 trillion a year cost. It's 1 in 5 people. Some people think it's 1 in 4. And it's a huge drain on productivity. Substance abuse is $250 billion a year in lost productivity. And so if we can mobilize corporations to provide the right environment, the right openness, and the right level of care, and in addition, obviously, we need to work hand in hand with providers so that the duration of treatment is consistent with the illnesses. While there may be parity in some plans, you don't get over depression or opioid addiction in 5 months, even though you might get over some other chronic disease or other disease in 5 months. That's not the way it works. So we've got to alter healthcare plans. We've got to get environments changed and modified. Could I have slide number 2? And that's really the focus of the effort that we're on, in addition to the work that we're doing in primary research. While this is still to be fully proven and vetted, we're going to actually do cost studies of the cost of healthcare and companies that are following these pillars. We believe that for every dollar invested in brain health, mental health prevention, you're going to get a $5 return for both in terms of productivity and reduced healthcare costs. Now that's an ROI that most CEOs can ascribe to and get behind. And so we're going to both prove that out and move forward with that. And of course, Tom will probably talk more about this practical application of technologies that are going to allow us to monitor people with these illnesses remotely through what's on your wrist, but with advanced technology, so we can not only look at the progression of disease, but also the therapeutic effectiveness of the innovative treatments we hope to bring to bear.
Thank you. Nora.
Yes, thanks very much. And it's a pleasure to be here. And I represent the National Institute on Drug Abuse, which is part of the NIH, and my boss is sitting over there, very ably leading the efforts. And so our mission is to do research to help us understand the problem of addiction. And what I can tell you is, from any perspective that you look at it, the current opioid epidemic is the most devastating epidemic of drug use that we've had in our country. And it's notable not just because it's the most severe, but there are other 2 things that make it unique. One of them is that it was actually born out of the healthcare system. So normally you have these epidemics of cocaine or methamphetamine that are the drug dealers that are bringing it here. But here, we as the healthcare system have to take the responsibility of recognizing that it was born out of well-intentioned practices, but improperly planned ahead. And we need to recognize it because it is at that essence, rectifying that is necessary to actually overcome the epidemic. And the third notable issue about this epidemic is all of those deaths that you were hearing about, 33,000 in 2015, 33,000 from opioids, could be actually preventable 100%, which is not necessarily the case for other diseases where we actually can we prevent Alzheimer's? We really don't know how to do it, but we can prevent the deaths from overdoses. Now, what is it that led to it? So one thinks, well, we are the healthcare system, but why did it happen? And there are 2 tides, almost like 2 tsunamis that hit at the same time. One of them is the enormous number of patients suffering from severe pain that require treatment, and the lack of adequate therapeutic interventions to help them. That was one of the issues that we had not in the healthcare system paid so much attention until the late 90s, when they decided that actually it was important to treat pain. Unfortunately, we did not prepare properly for that. And the other tsunami was that we knew in the country, yes, there's the problem of substance use disorders. We put them under the rug. It's them, it's not us. And so the healthcare system had never taken a responsibility of addressing addiction as a disease. In fact, most doctors didn't even actually ask for questions that related to drug use. And in medical students, most medical students don't get any training on how to recognize a substance use disorder, not to say how to manage it. So these 2 phenomena, the pain, needs, the patients, and the lack of understanding of substance use disorder, allow the improper prescription of opioids that fuel the epidemic. Now, why opioids? Well, we know a lot about opioids. Opioids actually, and the best acute analgesics that we have are opioid drugs. Morphine is recognized for that. And they act by stimulating the mu-opioid receptor. And they're extraordinarily potent and beneficial when you have an acute pain condition. They are life-saving. And it's because you have all of these mu-opioid receptors in the brain regions that are necessary for perception of pain. So then you activate them and pain is not there. But they are also highly localized in areas of the brain that are important for reward. So when you activate them, you have this extraordinary sense of well-being. And when you have those responses in the brain, you rapidly learn to associate that taking the drug with that pleasurable response, which is what triggers the initiation of the plastic changes that can lead in people that are vulnerable to addiction. And at the same time, we have these opioid receptors in the centers of the brain that allow us to breathe, which is also the other very black side of the opioid drugs, that actually by activating, they inhibit respiration, which is actually the cause, apnea, that leads to overdoses. So we have these drugs that potentially can have beneficial effect, but have these negative sides. And then the problem is when you take an opioid, you rapidly become tolerant. So while they're very good at acute use, chronic use requires higher and higher and higher doses to be able to produce the original state of analgesia. And that's why you increase the risk of becoming addicted, and you also increase the risk of overdoses. So as we look at it in terms of the epidemic, it's clear that two things need to be changing. One of them, that we actually have to recognize substance use disorders as diseases of the brain, and that the healthcare system can no longer ignore them. And we know a lot about how the brain changes when you become addicted. But the other one, too, is that there is a real need for patients suffering out there from chronic pain, from more efficient and safer therapeutics. Because if we don't address that, there will be a black market for the opioid medications. And as we were discussing, the CDC guidelines are an incredibly good step in the right direction. And we sort of say everybody has to learn about it. But we also have to recognize another aspect that needs to be put in the table, whether we like it or not. We need to do structural changes. Because right now, the recommended guidelines by the CDC are not necessarily covered by insurance companies. And I think that that is the other aspect that needs to be solved.
So yeah, let me just add, Nora, I think that's great. And if I just boil down what you've said, the two things are, these are real diseases. There's a real need. If I can add a third, which I think is often overlooked by not just the public, but by physicians as well, is that there are real treatments here. This is unlike many areas of medicine where we're still very much in the research phase, trying to find that magic pill that will help us with pancreatic cancer. Here, we have treatments that are 100% effective for many, many, many patients. And what's egregious is that it's not that we don't know enough, it's that we don't do enough on the things we actually know. So I think the challenge for us is really on the implementation side, trying to figure out how do we ensure that, as you were just saying, that you have a workforce that's educated and you have guidelines that people follow, and you have a process that actually ensures that the evidence is what people have access to. That's what gets delivered in practice. Because right now, there's some, over 300,000 behavioral healthcare workers in the healthcare workforce. Only 10% of them went to medical school. This is very different than the workforce for the rest of medicine. And the sad reality is that most of the care, if you want to call it that, for people with this range of problems is not in the healthcare system at all. It's in the criminal justice system. It may be in the schools. It may be amongst people who are in homeless shelters. It's just about everywhere except in the healthcare system. So this is really a very different kind of problem we have to start wrestling with. And what makes it, to me, most painful is it's not as if we don't know what to do or we don't have something good to offer. We have actually wonderful things we can offer, but they're not getting to the people who most need them in the way that they actually can be used.
Yeah, no, and I'm going to resonate with what Tom said. I mean, Lynn said to us, we need to disagree. But I'm trying to find a reason to disagree with you.
We'll find a way.
But absolutely not. I mean, I think that the notion here is because, and I'm very sensitive to it, because right now, the 21st Century Cures Act puts $1 billion for treatment of opioid use disorder. And my concern is exactly what you are saying. In the field of the treatment of substance use disorders, it seems we don't care about quality of care. So we are pouring money without any way of actually determining if that treatment intervention is going to go to a program that shows evidence of benefit. And we are, in fact. I mean, it is one of the issues that becomes extremely relevant. What we don't want to do is to put money that treatment is used in ways that have no evidence of benefit. We show no improvement, and then we say treatment does not work. And we don't have anything like that in the rest of medicine.
Richard, did you want to?
I just wanted to add on here, because continuing the through the looking glass aspect of this, I was in Ohio last week, and the Secretary Price actually came out to Ohio to see what was happening there. While that map is turning more and more orange and more people are dying, and the medical establishment and the insurance companies aren't reacting, people in the communities are. And we had a judge from a local drug court who was telling his experience where he started his own medication-assisted treatment program in the context of the drug court. And he's been doing it for over a year now. He's been doing 3,000 urine screens, 94% of which are negative. And I asked him, I said, where are the doctors? He said, there are no doctors. We do this in the context of the court. So there's so much opportunity to systematize this and do better.
If I can add on that, again, my career is not in health. It was in business, and I lost my son to this and left my career in business to come into this. So I'm bringing more of a business perspective, a little different than the others on the panel. For prevention, I come in and look at, all right, 4 times increase in pills, 6 times increase in deaths. Is it causal or correlated? Research shows it's causal. We have the CDC guidelines that will get that more in balance and reduce this by half of the people becoming addicted. On the treatment side, what we just heard, and by the way, I completely agree with Nora that part of the implementation of getting the CDC guidelines followed is better insurance coverage of the non-drug related remedies. On the treatment side, to pick up what we just said, it's not complicated either. It really is not complicated. We have, as Tom said, a lot of proven methods to help people in treatment. And there's dozens of protocols called quality measures in this field that doctors should be following. And there's dozens of them. And then we have this treatment system that's mostly outside of the healthcare system, rehabs, if you will, doing whatever they like. And not that this is bad people, but they're not educated on what they should be doing, and they don't have the qualifications in many cases doing what they should be doing. It's really not that complicated to improve this dramatically.
So
one last sentence. We just started just one last sentence. So we've just started put together a coalition of leading experts in the field to not create another report, but to create a working sessions and to come out with refining, distilling down all these evidence-based protocols to a finite list of the ones that move the needle the most, that have the best evidence behind them, that absolutely can be measured. And then we will publish a list of what can be measured, and then create a system to have them measured to see which providers are providing which ones and which ones aren't. And it's really been done throughout other forms of disease, and we can do it.
Yeah, let me just one thing about this, because I think we tend to assume that markets can fix this, and if we make this insurance reimbursable only if you follow guidelines, we'll be in much better shape. That's actually what drove a lot of the parity effort. We've had parity since 2009 in one form or another, and it's always been in the Medicaid system. I have to, unfortunately, remind everybody that 40% of psychiatrists in the United States do not accept insurance, and 55% do not accept patients on Medicaid. So the only other specialty that would compare to that is dermatology. So it's great to have these policies put in place, but again, the workforce doesn't really match with where the need is. And we're going to have to think much more carefully about how to incentivize the providers to both know the evidence, use the evidence, and to provide the kind of care that actually has an impact. As Nora said at the beginning, in a sense, what makes this particularly egregious is that we're sort of responsible for a lot of this problem. We certainly are responsible for not fixing it. It's been on our watch, and we have to ask ourselves, how are we going to do this differently? It's not simply about parity. It's not simply about providing insurance coverage. It's got to be increasingly, I call that the quantity problem. It's more the quality problem. How do you fix quality of care and ensure that people are getting something that actually is likely to be helpful?
I mean, if I may, and you know this field much better than I do, Dr. Insel, but studies have shown that many psychiatrists don't really feel that they were trained to address addiction, nor even major mental illness. You know, that what they want to do is to take care of a very different swath of patients, and they have the option of doing that. They don't need to accept Medicare, Medicaid, and they very carefully construct what their practice is around where they're comfortable. And I've wondered if there's really a fundamental problem from the outset of how we train people in that profession to, to attract people, to train people who will find it to be gratifying to treat people who have addiction, to treat people with major mental illness. I think that you can't just look at the numbers of people in the profession. It's also who they're willing to serve, and that they have a choice. And that's an issue with the profession.
So there was a study done. It was really a wonderful study done by Myrna Weissman about a decade ago to say, how are we training people in psychosocial interventions, which are a big part of this, as well as the medical ones. And the first point is, again, the people in medical school becoming psychiatrists represent less than 10% of the workforce here. So that's not who we're talking about. It's the family counselors, it's the psychologists, it's the social workers who make up the other 90%. Myrna's study looked at what they were trained to do, and at least it was less than 40% of the training programs provided any training whatsoever, even 5 minutes of training in any evidence-based psychosocial intervention.
And the corollary also is the DSM, right? The Bible for Reimbursement is very inaccurate as it relates to these illnesses and the spectrum of these disorders. And we were talking at the priority for research, et cetera, and prevention. I mean, unless you have a psychotic break, you're not able to have care reimbursed because you don't yet have schizophrenia. But yet we have techniques that allow us to intervene early and alter the course of the illness of these, but it's not covered by insurance. So it's better that we let people have a psychotic break and then help them, as opposed to do it the other way around. Clearly the wrong model.
Yeah, and I want to, again, come back to a point that Tom said, but extend it further. I mentioned that as medical school, actually, we were not trained neither in the proper management of pain nor in actually the recognition of substance use disorders. And in fact, if we were trained in pain, one of the things that we were trained as medical students, and still is believed by many physicians, is that if you have pain and you're given an opioid, you will not become addicted to it because that you will be protected, the pain will protect it from its rewarding effects, which of course the data has shown that it's incorrect. But then you go into medical school, and I went into psychiatry, and what's remarkable, and I come from New York University, is that actually you are not trained in the proper management of substance use disorders in your patients, even though I would say that at least 70% of my patients in the psychiatric unit had a substance use disorder. So the comorbidity of substance use disorder and other mental illness is more the reality than the exception. And yet, as training, we're actually dealing with them in a separate way. And this also illustrates the point that Richard was saying in terms of understanding why individuals that have, for example, a mental illness may be at higher risk of pain, and why also they are at higher risk of substance use disorders. So changing the training parameters and the way that actually we treat those individuals as if they had two separate diseases, as opposed to this is an integrated person where the intervention should be actually about that whole individual. Is another aspect that needs to be changed on the way that we are training psychiatrists and general physicians.
So I think we're hearing actually a lot of agreement among the panel about a few things. I mean, certainly that what has been feeding this epidemic has had to do with the availability of prescription opiates. And I would say not just prescribing practices, but also the availability of the opiates, because the prescribing, I think I probably trained around the same time that you did, Nora, and I was also taught that, but yet this epidemic really has been taking off in more recent times. And so I think that we've seen a very bad conjunction of misunderstanding of those who are teaching physicians about the ability to treat people with opiates without addicting them if they have pain, as well as very long prescriptions, as well as quite frankly, that we also had a lot of pill mills around the country that were kind of handing these things out like candy and weren't even examining patients. I think we shouldn't forget that. There were people that actually went to jail for those kinds of prescribing practices, and there has been a law enforcement aspect of this that I think has been very, very, very important. But I think what I'd like us to move to is that I think we have a reality today that's kind of, almost twofold. And one is that pain is real. People have physical and psychological pain, and I think that Richard made that point very well. And that needs to be addressed, that physicians still need to address pain. But also that addiction is very real, and that, as was pointed out by Tom, the deaths are the tip of the iceberg in terms of the many, many people who are today addicted. And whatever is done with changing prescribing practices is not going to treat those who are already addicted. And so I think we all agree about the need to double down on getting the prescribing practices, the availability of the prescription opiates to change dramatically. But what do we do? And this might have to do with the cutting edge science and the research that we're involved with, or it might have to do with policy changes. What do we do to address the very real problem that we have, the enormous burden of addiction in our society, but also that we do need to be able to address the very real pain, whether physical or psychological, that people are suffering from. And maybe start on the other end this time with Nora.
And Lynn, you are saying something that we haven't really discussed, and is the notion that opioid use disorders, when you become addicted to your opioid medication, or you become addicted to heroin because you transition, it's cheaper, it's more available, or you get, unfortunately, addicted to one of the synthetic drugs that are starting to emerge in our country, like fentanyl. We have treatments and we have medications, and they are quite effective. We have 3 classes, methadone, buprenorphine, and Vivitrol. We need many more, but those 3 have been shown to decrease relapse, to actually prevent overdoses, to improve outcomes on patients suffering from neonatal abstinence syndrome, because that's something that we haven't discussed even there, and to actually protect individuals from getting infectious diseases associated with injection of drugs like HIV or hepatitis C. But we're not using them. And a very small percentage of patients that could benefit, that have an opioid use disorder, are given these medications. And so one of the issues that we could do right now is expand access and adequate coverage for those individuals that could benefit from these medications, while at the same time incentivizes research and development for alternative medications that can improve compliance and outcomes in these patients. So I think that this is something that I would like to just point out as another one of the strategies that we need to deploy to be able to revert the epidemic.
Could I have slide number 3, please? Slide 3. One of the ways that, if I had a wish list, would be to really allow us to break down the silos that exist in terms of much of this research has been done in areas of where tech transfer offices of major universities have sort of held this data that we know about and hasn't allowed other people to access it. And in an area of constrained NIH funding, although I think we should all applaud that more money came yesterday, which is great, but it's nearly not.
Yes,
That's right. And we need twice as much, not just another $2 billion. But we need to use this money as wisely as possible. And we believe that multi-site studies in collaboration with open science and data sharing is the way in which we're going to go faster and farther on both opioid addiction and all acts of brain health treatment. We've actually done a study in traumatic brain injury, which results in a FDA approval in 1/3 the time and 1/5 the cost as an evidence of that. So this is something, as citizens, you can help demand that people share their data, because that way we're all going to go faster.
Thank you for that.
Yeah.
Well, it's good that it coming before Gary, because I think we'll say something probably similar, if I could guess, which is, in terms of policy, the term of art you'll hear is MAT, medication-assisted treatment. MAT is the combination of pharmacologic interventions plus psychosocial counseling. Both are important in the brain. They're acting on different parts of the brain. And it doesn't happen over a week. It happens over months, if not years. The evidence exists. from a policy perspective, if we started applying MAT and measuring outcomes and discerning which patient populations are more responsive to different types of MAT, we will go a long way. If we just start measuring things, so much of the treatment that's provided in the country right now is based on recipes or concoctions or lore or religious beliefs that have no evidence. If we just start measuring, we can make a lot of progress.
Can I ask a question? Does the coverage that people have allow them to receive MAT over a long enough period of time? I mean, this
Does
is
not.
one.
It
This
does
is
not.
one thing that I hear, and that is that people have to terminate treatment before cure. Where do we do that? Where do we do that?
We had a patient in Ohio. The mom brought her daughter into the clinic because she was a chronic opioid user and she was getting ready to relapse. And there was no coverage. There was no coverage provided until you'd relapsed. So the recommendation from the ER was send her home and have her drink a fair amount, because then she could come back in and qualify under an alcohol benefit that they had.
But they go home sometimes and actually overdose. I mean, there are just so many case reports of people who don't complete therapy, but they're still in the social networks. And
Well, there's Nora and Tom can speak to it more, but there are no real guidelines about the length of therapy. We know about initiating, we know about preventing drug overdoses within the first 4 weeks. There's some somewhat longer series, but there aren't real long series to explain what the right treatment protocol is for these patients with a chronic disease.
Gary.
I don't think I'm going to add anything new except maybe just emphasize a few points that have already been said. I think Tom said a really important thing here that I want to emphasize, and if it's probably one thing to take away from this session, this is not like some other diseases that we don't have the answer to. There is enough knowledge that exists today to dramatically reduce and save thousands, tens of thousands of lives if we just put into action what we already know. And to put into action what we already know, we don't have to recreate the wheel. We can do what other disease states have done. We need to get consensus on what is the standard of care. You just heard a lot of it right here. You've heard of it from everybody. It's open research. It's further research that needs to be done so it can continuing source of research. It's medication-assisted treatment. It's simply just doing what we do for other diseases, taking what we know. There's a long list, shrink the list down to the ones that have the most impact, and create a system where we're measuring it and doing further research based on that evidence, but also measuring so we can tell which providers are doing it and which providers aren't. And that information should be public knowledge to consumers so they can go to doctors, the providers who are following the evidence-based practice. It should be to insurers. It should be to government agencies who are funding a lot of this stuff. It's not that complicated. And so the good news, if there's one takeaway that I would suggest, is we have the information to make a dramatic impact here, and putting it into a system that we can make real impact. It's just replicating what's been done for other disease states. And I think a lot of us are moving forward in different directions to doing it.
Well, but what you said is interesting to me from the standpoint of how more generally in healthcare we're trying to move toward a quality-driven system, an
Right.
outcomes-driven system, rather than a, if you may, procedurally driven system. You know, and it isn't clear to me that we yet have the metrics for that, for this issue, and that's going to be extremely important. If we're going to be ranking, or if we're going to be rating, we're going to need to have that. I see Tom leading forward, and maybe you've got an idea about that, Tom.
Yeah, so it's good I'm coming at the end. So I'm the guy from the tech company. And you know, Alphabet, we love hard problems, like mapping all the roads and streets in the world, or organizing all the world's information and making it universally accessible and free. Those are the kinds of things that the company likes to take on. This is a good problem for us. If you just think about what you've heard here, the issues are to some extent access, to some extent fragmentation, delay in care, the problem with understanding quality of care and having good metrics and good measurement, so you have good objective assessments that are continuous. Those are all issues that technology can help us with. Technology is not a solution here, but there's an opportunity, I think, to really make an enormous difference. And it's possible in the same way that, you know, you think about how the biggest taxi company, Uber, owns no cars, and the biggest hotel chain, Airbnb, has no real estate, and the biggest source of merchandise, Alibaba, has no inventory. This may be your mental health care system in 5 to 10 years. This may be what it looks like. It may not be the bricks and mortar. It may not be the same workforce that we're looking today to provide evidence-based care for. It may be a matter of providing information, providing data, having consumers drive the quality that we're all talking about, and actually make this more of a movement than simply another app or another opportunity to try to change the healthcare system, which, by the way, is not where any of the people who need this help are looking to get help from. I mean, it's really, we're talking about a different kind of problem. And it may, like Uber and Airbnb, it may need a different kind of solution. So I'm hopeful. Actually, I think there's a lot we can do. We just haven't really started to think enough about how to bring innovation into this space and maybe leapfrog in a way that would actually change morbidity, change mortality in the short term. Because I think we know a little bit about how to do that. It's not a research question as much as an implementation question.
Well, I want to get some more thoughts from the panel about that issue, because one of the things I think that is unique about this set of diseases is the extent to which our society still stigmatizes people who have them, frankly. And that used to be true of many diseases. It used to be that when we didn't understand infectious diseases, that people with infections would be shunned. People with cancer would be shunned. We still have that problem in the field with mental illness and addiction. And then we wind up, instead of spreading out the resources for treating, we bring people into, okay, if you're going to get your medically assisted treatment, you go to a special clinic where the other people then that you're interacting with, by the way, are other people who have the same behavioral issues you have. I'm not sure necessarily that's the smartest thing in terms of what we know about behavioral sciences, that we're helping to reinforce certain social networks by bringing people together for treatment rather than making treatment more broadly available. But how do we move that forward, that piece of it forward, that I think is such a barrier in so many of the things we've talked about, whether it's policy, the workforce, or the willingness of basically ratepayers to pay for this treatment?
And you know, we are a research agency, so we actually try to tackle problems that relate to basic science, but we also try to tackle problems that relate to implementation. And the way that I very rapidly learn is that science by itself is not going to lead to policy. You need to be much more smarter than that. So one of the things that we do is to fund research that can show unequivocally the benefit of a policy. So in that case, for example, we funded several investigators that, not surprising, are showing that integrated care, where you include the substance abuse treatment as part of the medical condition, whether it's an infectious disease or an emergency room, actually leads to much better outcomes than when you do it separately. Outcomes in terms of the patient that not relapsing, but in terms of dollars that are being saved. So from that perspective, integration of care can be shown to be cost effective.
We intend to make that very much a part of this workplace initiative. Behavioral health, you know, in its finest form, you have to have a checkup from the neck up. You need to have all aspects of it. You can't be your own chief medical officer. You can't be compliant to medication, exercise, diet, or whatever if you're suffering from severe depression or other illness. And you will have comorbidity with other serious diseases like heart disease, diabetes, cancer, way earlier. You'll die 20 years earlier from those illnesses because of your inability to be your basically chief medical officer because of this illness.
I think that's a great point.
To the extent that that point is correct, that restricting these social networks in that way, it could be deleterious. The limit condition that proves the point is to go to Cook County Jail outside of Chicago and see, or here in LA, the world's largest psychiatric institutions are our criminal justice system.
Yep.
And they are literally, they're out of medieval times. And the quality of care is abysmal, yet it's better than what people get in the community. They leave, they plea out. These are jails, not prisons. They plea out, end up in the community, they recidivate often to come back into the system and get better care.
Number one recidivist prisoner is bipolar male alcoholic.
Interesting.
You know, it's interesting.
Untreated.
untreated when he's out, treated when he's in.
Exactly.
Clearly, I guess the one thing I can add is I've been up here mainly commenting on some things that I think can be done fairly quickly and easily to dramatically reduce the suffering. And reducing shame and stigma is not a quick fix. It's going to take time because it's a change of hearts and minds. And it's changing the way that our tolerance, how we think about people who have a substance use disorder or depression or schizophrenia or something like this. This is not bad people. This is good people with a bad disease. And there is no one easy fix for this. It takes the bully pulpit of the President of the United States. We have also been developing a workplace toolkit for companies to understand the cost that addiction is causing their companies, similar to what's being done in mental health. And we're creating a toolkit around it of once you understand the cost, and the ROI is similar, like 5 times, it's unbelievable, the returns. Of our number one recommendation is the CEO of each company coming forward from his or her bully pulpit with a statement that, okay, we've done it with other diseases, we can do this over 20 years, or we're going to do it today. Today, I am CEO. Here's how this disease touched my family or someone that I know. This was a good person and a good family, and we are going to start as a company treating this like a disease just like any other. Our corporate policies are going to reflect it. Our insurance policies are going to reflect it. We're going to do a walk on a Saturday morning for addiction or mental health the way we do for heart disease or diabetes or cancer or anything else, and it's a cultural thing. And it can change rapidly. This is not recreating the wheel. It's been done for other diseases.
Just maybe to finish off with what Gary was just saying, and I completely agree with this. I just need to say how to manage expectations. These are really tough problems. 40% of people with schizophrenia do not think they have an illness. And most people with severe depression are hopeless, helpless, they feel worthless, and the last thing they think they deserve is to feel any better. So they are not seeking care. They're not trying to feel better. This is a really difficult problem. It's the only group of illnesses in medicine in which the illness itself often precludes its own treatment. That makes this particularly difficult. I love the idea that if you could fix stigma, you could fix the problem. It's more complicated than that, and it's something that we're going to have to understand in a much deeper way to get people engaged in their own care and doing more for themselves, because the disease becomes the enemy at that point.
I just, in closing this session, need to thank this wonderful panel. If you could all join me in giving them a hand. Thank you so much. This is obviously a very serious, it's a very pressing issue. There are some ways forward, and I thank you for illuminating them, all of you.
Thank you.